Welcome to Doctors on Call. I'm Jenna Miller. Staring at a computer monitor, tablet, or phone for hours on end has become a part of the modern workday and lifestyle. And inevitably, all of that staring can put a real strain on your eyes. Somewhere between 50% and 90% of people who work at a computer screen have at least some symptoms of eye trouble. Taking care of your eyes and your health is the first step to preventing vision loss from common eye problems as you strive to maintain healthy vision for your lifetime. EyeCare is our topic on Doctors on Call with Dr. William Clifford from Garden City.
Presentation of Doctors on Call is made possible in part by an underwriting grant from
Patients should not have to drive long distance to receive health care, which is why Norton County Hospital works hard to keep care close to home. The hospital now has 2 clinics in Norton and Logan. Information is available at www.ntcohosp.com.
Gove County Medical Center in Quitter. Healing through caring.
Blue Cross and Blue Shield of Kansas, serving more than 870,000 Kansans in various programs. Value Kansans Trust. Blue Cross and Blue Shield of Kansas, an independent licensee of the Blue Cross and Blue Shield Association.
Russell Regional Hospital, experts, neighbors, friends.
Dr. William Clifford joined the practice in 1995 and is a co-owner of Fry Eye Associates in Garden City. A 1976 graduate of the Air Force Academy, Dr. Clifford flew the F-15 jet fighter in the Air Force for 6 years. He attended the University of Southern California Medical School from 1985 to 1989 and then completed an eye surgery residency and fellowship training in glaucoma and cornea at the University of Oklahoma. After a year at the prestigious King Khaled Eye Hospital in Riyadh, Saudi Arabia, Dr. Clifford moved to Garden City to join Dr. Luther Fry in practice. He specializes in the treatment of cornea problems, glaucoma, cataract surgery, and refractive surgery. Certified by the American Board of Ophthalmology, Dr. Clifford is very active within the Kansas Society of Eye Physicians and Surgeons and the American Academy of Ophthalmology. Give us a call at 1-800-337-4788 toll-free with your medical questions about eye care on Doctors on Call. Doctors on Call brings you information which may be useful to you when you see your own physician or specialist. Let's go ahead and get started with some questions of our own while those calls come in.
Sure.
First of all, when you examine someone's eyes, what diseases are you checking for?
Well, when I walk in the room, I'm looking at the whole patient first. I always say I enjoy the patient attached to the eyeball. And I want to see if that patient came in on a walker or they have a cane. How are they holding themselves in the chair? Do they look tired? Do they look ill? We take kind of an outside-in approach to the eye, so we're looking at the lids, the face, and how their gaze would be. Of course, at the eye level, we're looking through the structures of the eye, looking to see that they have a healthy cornea, the absence of cataract. Especially for diabetics, we want to dilate that patient and look inside to see if they have any diabetic eye disease.
Okay, what are the early warning signs of a detached retina and how is that treated?
Well, we try to get patients in right away where we suspect detached retinas. Often patients will sit at home thinking their eye condition will get better. I prefer patients who call in with possibly small problems and get in early with those small problems instead of things like detachments. Generally, patients have floaters in the eye, although lots of us have floaters. They're usually benign, but floaters may lead to shadows and actual blockages of parts of their vision. So any patient who doesn't see part of their field of vision should be seen by an eye care professional right away.
And what happens if they don't come in and that gets worse and worse?
Well, vision loss is initially peripheral, but it will progress to central. And if that is not repaired rather emergently, that patient may have permanent visual loss. The repair percentage is very good. So if patients come into us early, we do have to refer them. We don't have retinal care or retinal detachment surgery care in Garden City. So we're actually referring patients to Wichita, Amarillo, Colorado Springs, many of the larger cities where retina specialists will do the surgery. If they're operated, their chance of success is quite high.
Okay, we're going to go to the phone lines now. We've got Connie on the line from McPherson. Go ahead, Connie, with your question for our guest tonight. Connie, are you there?
Yes, I am.
Okay, go ahead with your question for Dr. Clifford.
Okay, my question is, I'm 67 years old, and a year ago I was diagnosed with low-pressure glaucoma. I have had the laser beam treatment and the betamol drops nightly. My question is, my pressures have always been 11 and 12. Could you explain a little bit more to me what low-pressure glaucoma is and what pressures we are looking at?
Well, Connie asked a very good question, because normal pressure would go from about 8 to 22. So as you can hear from what she describes, her pressure is on the low end of normal. Unfortunately, she must have been diagnosed with damage to her optic nerve. Glaucoma isn't about the pressure, it's about the damage to the eye structures. And I don't doubt, given her explanation, that she's being seen by someone quite competent who understands that the damage to the nerve is what is trying to be prevented. She describes using drops and also having laser treatment. There are surgical options as well, but it's difficult to get pressure to stay consistently in the high single digits. We don't want to get too far below that level of 8, because there are other problems there. So we may be, in patients with low pressure glaucoma like Connie, we may be looking at low blood pressure, we may be looking at sleep apnea and other systemic diseases. So I would encourage folks like Connie to make sure their physician, their general medical doctor, knows that they've been diagnosed with low tension glaucoma, and they get the other things checked out.
So are there different levels of glaucoma?
There are two main different types. One would be open angle or open drain glaucoma. The other would be closed angle or closed drain glaucoma. She describes almost a third type, and I can certainly list about 20 different variants. But most patients in the United States have so-called open angle glaucoma, where the drain of the eye is working, or is at least available to work, but the fluid for some reason is not getting out, and the pressure in that case usually is elevated. And we have many, many treatments for elevated pressure. Connie mentions 2, drops and laser surgery. But again, we can go to the operating room. And in this day and age, we have multiple options for patients. We're actually entering an era of minimally invasive glaucoma surgery. In the past, glaucoma surgery has been fraught with many, many complications and really lifelong challenges for the patient and the physician. Now with some of our minimally invasive procedures, we can offer patients efficacy with minimal side effects.
Excellent. Okay, we're going to go back to the phone lines now. We've got Kendra on the line from Victoria. Hi, Kendra. Welcome to Doctors on Call. Go ahead with your question for Dr. Clifford.
Yes, I'm in my late 30s and never had any type of eye trouble before. Don't wear glasses or contacts or anything. And once in a while, though, I notice that I feel like I have something in my eye, and I can search the entire eye, and I cannot find anything, but it bothers me for quite some time, and then finally it'll just kind of work its way out. So I was wondering what that might be or what I can do to help with that.
Well, she brings up something that plagues many patients, especially here in dry western Kansas. I often kid my patients that I'll prescribe moving to Florida as one of their solutions, where it's a little more humid. But seriously, a young woman may have dry eye, so it may be hormonally related, and any eye care professional will be able to diagnose dry eye, for which there are many treatments, many over-the-counter, and there are actually now 2 prescription treatments for dry eye. One disease that's often overlooked, particularly in women, is called superior limbic keratoconjunctivitis. We call it SLK, which is a lot easier to say. It would be a redundancy of tissue under the upper eyelid, and it is often undiagnosed. It plagues patients and gives symptoms such like she describes. So if she's not having relief from over-the-counter or even prescription dry eye treatment, I would suggest she seek someone who might be able to diagnose SLK and rule that out.
Okay, very interesting. Let's go back to the phone lines. We've got Dennis on the line from Whitewater. Hi, Dennis. Go ahead with your question for our guest.
Hi. I was just recently diagnosed with posterior vitreous detachment, and I was kind of curious as to what will happen down the road. The doctor that I saw didn't seem all that concerned, but I'd kind of like to know if there's any treatment or if it's just a waiting game.
Well, I'd like to tell Dennis that he sensed the doctor wasn't too concerned is probably a good thing. That doctor thought this is going to be run-of-the-mill floaters accompanying a separation of the gel in the back of the eye. This is a natural process. All of us 30 and over are susceptible to this, and generally it is a benign condition. It can lead to retinal detachment, as we talked about before, so if Dennis were to have any blockages of his peripheral vision, he'd want to get back to that doctor right away. Floaters, which are caused by the posterior vitreous detachment, can often be just the bane of somebody's existence. They're constantly in the way, they bother them. In the past, we haven't had treatment for floaters except going to surgery and physically removing them. Now there's actually laser treatment, and we've made that available in our office to mitigate floaters. We can break them up within the eye and limit the awareness that the patient has of the floaters.
Excellent. Okay, we've got another caller waiting to ask the question. This is Grace on the line from Salina. Thank you for calling Doctors on Call. Grace, go ahead with your question.
I have floaters in my eyes, and I also have a lot of, I call it gravel. Is there anything I can do for that? Thank you.
Well, Grace brings up two topics we already talked about. One is the floaters, and just from the tone of her voice, she's probably a little bit older than our last caller, and she may be someone who's amenable to laser treatment for those floaters. As far as the gravel in the eye, again, that's another way that patients describe dry eye, and I would ask her to consider over-the-counter tear treatment, but if that's not sufficient, to seek care with an ophthalmologist or an optometrist and to find out what is the root of her dry eye. You know, we think about dry eye as just we don't have enough water, tears in our eyes, but the tear film is very sophisticated. It's mucus, like that layer inside your mouth. It is a water layer, and then it's an oil layer over the top, and if any of those components are out of whack, then you're going to have symptoms. So someone needs to diagnose that and find out which layer really needs the work or which needs the prescription treatment in order to relieve these symptoms. In her case, it may also be lid malposition or eyelashes rubbing into her eye. And that can lead to serious infections of the eye and really needs to be checked.
What causes the floaters?
Well, the vitreous of the eye, the gel filling the eye is clear, but it's mainly water. It's about 98% water, 2% fibers. And as we age, again, age over 30, so you can be very young, that gel, like a bowl of Jell-O on the table, liquefies. And the jelly portion pulls away from the back of the eye. It may pull some tissue with it. And those pieces of tissue are out in that gel moving about. And you're actually not seeing the object, you're seeing a shadow of the object cast upon your retina. Lots of us have them. I went through floaters last year, fortunately resolved without any treatment. So I think most patients should kind of persevere if it's persistent. If it's a hazard, of course, to driving or it's just stuck in the middle, they really need to seek treatment. And fortunately, they can probably have laser treatment now instead of going to an operation in an operating room.
Okay, back to the phone lines we go. We've got Robert on the line now from Hayes. Hi, Robert. Go ahead with your question.
Oh, hi. Thank you for answering my call. I had cataract surgery. Let me turn my TV off. Excuse me, just a second. Okay. I had cataract surgery, possibly a year or maybe 2 years ago. I was followed by eyelid surgery by a different surgeon. My wife indicates to me now that my eyelids are drooping again. I've had a tremor under the left eye, and both eyes were treated. But I have a question as to what I should do, especially about the tremor under my eye.
Well, Robert has access to very good eye care in Hayes. I mean, there are two excellent ophthalmologists there, Dr. Picorni and Dr. Hollweger, and many good optometrists. Cataract surgery sometimes does lead to lidosis, as we call it, or lowering the lids. Of course, so does aging. So it may be coincidental, and that a patient would have the lids repaired after cataract surgery is not uncommon. That he's now having recurrence to the eyelid symptoms needs investigation. He may have Parkinson's disease, he may have myasthenia gravis, he may have many other systemic diseases which could be leading to this. And I do think his medical doctor needs to be aware of that, but he can return to his eye surgeon and let them investigate the recurrence of the lid drooping.
Okay, very good information. Now I want to go back for a second with the floaters because we've talked a lot about that. Is there, you had said a lot of the patients just need to persevere. Is there any prevention to keep that from happening in the first place?
There really isn't. I mean, most of us like prevention. We like to take supplements or use exercise to prevent conditions, but floaters is one of those processes of aging that is very random, to be honest with you. And again, it's generally benign, although can be pretty annoying. But I couldn't offer an ounce of prevention of floaters. Sorry.
Excellent. Okay, no, that's good to know. And also, we were talking about glaucoma a little earlier on in the show. How do you diagnose glaucoma?
Well, we have many tools. One, of course, we're going to monitor the pressure. We're going to look at the optic nerve because that's where that's the business end. That's where the eye is attaching itself to the brain through that corridor or the conduit of the optic nerve. So the optic nerve has to be examined. We also have tools to examine the optic nerve. We can objectively, literally examine the thickness of those nerve fibers going back to the brain, and certain levels of thinning indicate certain levels of glaucoma. We also can have the patient take a field of vision test, and they can give us their really subjective view of the world, put it on paper, and we can see if there are actual defects. Unfortunately, with glaucoma, you can have almost 90% damage of the nerve before you have functional damage. I've had patients come in seeing 20/20 in the eye chart, and they couldn't see the floor unless they looked straight down at it. That's how badly their peripheral vision was affected. So better to catch the nerve damage well before the functional damage. So especially if it's families with glaucoma, African Americans are very susceptible, probably 8 times Caucasians in this country. So folks in risk groups, folks with diabetes, really need to be examined, have their optic nerves looked at, and to see if they have glaucoma. Unfortunately, about half of people, it's estimated in this country, don't even know they have it. So there may be several million patients walking around with glaucoma who aren't aware of it.
Incredible. Okay, we're going to go back to the phone lines. Robert is back on the line from Hayes. He has another question. So go ahead with your second question, Robert.
Yeah, well, it's the same one actually. Just the doctor started, the call was cut off, and I didn't get the answer. I will repeat what I said. I've had cataract surgery in both eyes. It was preceded, I believe, with the tremor under the left eye. But I've also had eyelid surgery for drooping eyelids. My wife informs me that my eyelids are drooping now as before.
I don't think he heard the rest of your answer.
Sorry, Robert.
No.
I did go through some of your symptoms and the potential for disease, but I really would like you to return to your ophthalmologist and have investigation of the condition because it has recurred.
Okay, excellent. Thank you. Now, we were talking about there's really no prevention of floaters. Is there any prevention of glaucoma?
Again, prevention is detection in glaucoma. Again, in African Americans, in families, it's very common. Here in Western Kansas, we see a lot of what's called pseudo-exfoliation glaucoma, and this is a process where the eye produces a certain protein, and it is deposited within the drain and actually clogs up the drain. So families have this disease. If you know of a family that has a family member who has pseudoexfoliation, you should be checked to see if you have that condition. So again, there's no exercise. Coffee hasn't been related to creating glaucoma. There's nothing you could eliminate from your diet. Medication-wise, unfortunately, patients often don't have a choice in that, but steroids can create pressure in the eye. So any patient who is on any kind of a chronic steroid medicine for asthma, back pain, getting chronic injections, even multiple injections for allergies can summate and collectively lead to elevation of pressure.
And are there any symptoms involved?
In the more common open-angle glaucoma, unfortunately, there are none. It's a silent thief of vision. And until the very end stage, patients are generally unaware. Pressure has to be literally double normal, in the 40s, before it hurts. And patients can gradually raise their pressure and come into us in the 60s and 70s, still not feeling it. In the other, less seen form of angle closure glaucoma, that's going to be a sudden attack. That's going to be instant pain, decreased vision. Patients know something's wrong. We just had a woman come, brought a family member from Mexico, pain in one eye, dimming vision in the other. She was in a glaucoma attack. So she had laser treatment in one eye, surgery in the other, emergently, to reverse that process. So yes, they'll know if they have angle closure, but again, it's not as common in this country.
Okay, what is macular degeneration?
Well, macular degeneration is generally an age-related loss of layers of the eye tissue that are the light-sensitive portions. Again, it is very much within families, and it leads to central blindness. So patients who have macular degeneration never go completely blind because their peripheral vision stays intact, but they lose the ability to read, to drive cars, to recognize people. And it's a very difficult situation. Again, two types, simplifying it. One would be a dry degeneration, which would be a slow atrophy of these retinal tissues. The other type we call wet degeneration, and it involves the rather sudden appearance of new blood vessels within the eye. The body's a wonderful thing, and we're lucky we have many reparative mechanisms within our bodies. Unfortunately, when the body tries to put new blood vessels in to repair macular degeneration, they can leak, and the leakage causes an even worse problem. Fortunately, there are many treatments for macular degeneration, this wet type especially. The dry, slowly atrophic type, not much can be done. We do encourage patients to do nutritional supplementation, particularly supplements containing lutein. But for the wet degeneration, if they come in right away, they can have injections of treatments to stop these blood vessels from growing and leaking in the eye.
Okay, and what is a cataract?
Well, cataract's something most of us eye surgeons spend 80 or 90% of their day on. I did 17 cataract surgeries this morning before I drove here. It is a clouding of the natural lens of the eye, leading to dimming of both near and distance vision. We sometimes see it in children, rarely in early adult life, and of course it is something which grows with aging. I often tell patients it's caused by mileage, survival. Probably the sun and exposure to UV light is implicated. Again, our friendly steroid, which is used for so many things, can create cataract as well as high pressure in the eye. So patients who are on a lot of steroid often get early cataracts.
So if you said you did 17 this morning, I'm assuming it's not that invasive to take care of.
No, I mean, patients with cataract today enjoy a wonderful 8-minute operation, no shot, no stitch, no patch. And people, we're fortunate to be in this day and age where technology, particularly for cataract surgery, is so wonderful. We can literally restore the vision of our patients, and it's a privilege to be able to do that for patients.
And when should a patient come in if they have a suspicion that they might have cataracts?
Again, the symptoms are a painless loss of vision, so they wouldn't really know it's cataract or diabetic eye disease or some other eye disease. They just need to be seen by their eye care professional. Generally, patients are seen by their optometrist if they're glasses wearers or contact lens wearers, and they'll notice the cataract. So I would say anytime you're having trouble driving, particularly at night, you're not recognizing faces, or you're having trouble reading things that you know you should be able to see, someone needs to see you to find out why that condition has occurred.
Okay, we have just a few seconds left. You might tell our viewers, even if they don't, one of the callers said they didn't think they really had too many eye problems, when should they go see their optometrist?
Well, I think an ophthalmologist or optometrist should be seen yearly by patients. I mean, so many systemic diseases show up in the eye that it can be a huge preventative benefit to have that discovered early. And glasses, contacts, and some of our drops and surgeries can correct so many conditions and give people a more enjoyable life.
Excellent. We thank you so much for joining us tonight,
Nice to be here, Janet.
Dr. William Clifford from Garden City. On our next Doctors on Call, we'll be discussing pet health. You can email questions to us for our next program at doctors@shptv.org or tweet us at #.call. Thank you for joining us for Doctors on Call. I'm Jenna Miller.
Presentation of Doctors on Call is made possible in part by an underwriting grant from
Patients should not have to drive long distance to receive health care, which is why Norton County Hospital works hard to keep care close to home. The hospital now has 2 clinics in Norton and Logan. Information is available at www.ntcohosp.com.
Gove County Medical Center in Quitter. Healing through caring.
Blue Cross and Blue Shield of Kansas, serving more than 870,000 Kansans in various programs. Value Kansans Trust. Blue Cross and Blue Shield of Kansas, an independent licensee of the Blue Cross and Blue Shield Association.
Russell Regional Hospital. Experts, neighbors, friends.